a low sensitivity of about 50 to 60, but with a specificity of 95%. Unlike the VIA, which has a higher sensitivity rate compared to the pap smear. So sometimes it can be subjective. Then also the turnaround time, waiting time is very long, because sometimes it may need for a patient to go home, wait for a week or so, then she comes back. And that one, you see, it will increase the anxiety of this patient. And sometimes we get these patients, they get lost. You try to reach them out and they don't come back because of that anxiety and fear of unknown. So what are some of the symptoms? The signs and symptoms, we know that usually it is asymptomatic. This is a cancer which is usually asymptomatic in its initial stages. But if you start seeing signs and symptoms, it means it has already advanced. So what will you observe? You'll be able to observe abnormal bleeding either when a client tells you, when I'm having sexual intercourse, I'm seeing some bleeding. And then we have those intermenstrual periods bleeding, apart from other conditions that may bring about the intermenstrual bleeding. But this one, you will still have the bleeding in between the periods. Then for those postmenopausal women, they are not expected to have bleeding, but you find that a woman aged above 50 years comes in complaining of vaginal bleeding. You need to be on the lookout. Then there is this unusual vaginal discharge, which has a characteristic smell. And also it is a discharge which is disturbing for this client. It's not a normal discharge. The patient will always complain about it. Then you have pelvic pain and discomfort when during sexual intercourse. These clients, you need to really check about them. When somebody is screened and is found to have a cervical cancer, usually we do clinical staging. And they are usually staged in 4 stages. You will find that a client is being told you are at stage 1, stage 2, stage 3 or 4, stage 1A or B, 2A or B. What does that mean? It means what? The stage 1A, it is just within that cervix, but you can just observe it under the microscope. It is small that you need an aid, a visual aid to see. The B1 is an obvious. You can see it with your naked eyes. When it extends to stage 2, it means there is that extension to the upper vagina and parametrium. But when we say you have a 2A, it means it has affected the upper 2/3 of the vagina. Remember, the cervix is just above the vagina. So when it starts coming down, it means what? The 2/3, when it has covered the 2/3, the upper 2/3, it means now that is stage 2A. Stage 2B, it means it has involved also the parametrium. Then we have extension to the lower vagina and the pelvic walls. The lower third of the vagina means the lower part, it is almost outside the vagina. It is in the lower third of the vagina. So that means it is stage 3B. The crucial part here is, if you have a stage 1 and up to stage 2A, there you can be done a surgery. But when you have 2B and above, it becomes very difficult for you to benefit from surgery. Okay. With the stage 4, it means it has undergone metastasis, and it has gone to so many other organs like the bladder and the rectum, and then also the distant organs, the ones that we've talked about, like the lungs, the brains, and the liver, and all that. So those are some of the clinical staging when they go and check. When they send you for a CT scan, when they send you for an MRI, they're looking for how far has the lesions gone. So how do we treat this? When it comes to our treatment, from the previous presentation, you remember we were told that we have several treatment modalities within our county. But now, this treatment, we are having them even within our primary peripheral facilities, that is the dispensaries and others. So what happens? What happens is our staffs have been trained to screen and treat. But because of some hitches, you may end up like all clients who have been screened found positive, they are all not being treated because of few hitches here and there in the system maybe. Now, we have the cryotherapy, the thermoablation machines within our facilities. When we have the lesions, the via positive lesions that we've observed, and when it is covering the cervix and it is not covering more than 75% of the cervix, we are able to do the cryotherapy and the thermoablation. But if it is covering the cervix more than 75%, we need to take them to a center where we have the lip. And when we are doing a lip procedure, it means we are just removing the whole part that is affected for the cervix. Cold knife conization is also done, but it usually is done in theater. Lip can be done as an outpatient in our clinics, in our facilities. Currently, it's being done in Coast-General and Port Reitz. So it is something that is doable, because after taking that sample, it is usually done under an aid of a colposcopy machine, which magnifies the cells and it shows you where are you going to cut and what are you going to remove, so that you can be able to see, visualize very well, and then take that sample for further examination, and we know which stage we think our client is. So for this, we are trying as much as possible to apply the single visit approach, which we need to really sensitize our people, so that whenever you are found with a positive lesion, when you are told that we need to treat you, do not think twice, or don't say, oh, let me go home, think about it and come back. Just agree so that you can be treated and you go home. So these are some of the devices that we use. We have two different devices that we use for thermoablation. It is a machine that treatment takes only 30 seconds. And this one, we apply heat. But when it comes to cryotherapy, it usually freezes the cells. This one burns the cells, but a patient won't feel any pain when treatment is taking place. It is usually having a battery that is fully charged, and it has a probe. Depending on where the lesion is, the healthcare provider will be able to know which kind of probe the healthcare provider needs to use. This is our and how it is usually used. What it does is it enlarges the cells of the cervix so that you can observe where is the abnormal cell and where is the normal cell, so that through the speculum, you can be able to observe the cervix at this point. And then we are able to pick where are we going to take, either we are taking a sample, we are doing another lip procedure, or we are doing anything under magnification. So when we do lip, it is just like a small ring. You can see it is a small ring. And when this is when it is affected. What happens? You using a colposcopy machine, you have demarcated this is the point, and you just come in with the lip machine and you remove that point. As you remove, there is no worry that you will be able to bleed, because the machine itself, it burns those vessels, and so it ends up closing the vessels as you move, and then you remove the sample, and then you put in the preservative and take it to the lab. And then you wait for the results for the next patient for the results to come later on. So what about the suspicious lesion? The suspicious lesion, this is an advanced stage. Those ones who have had an advanced stage, usually we take them to the theater and do examination under anesthesia for staging, because we need to stage this patient and find out which stage are we. And some of them we take biopsy for
time is not on our side, so please wrap up in the next 2 minutes, please.
Almost done.
Yeah.
Yes. So when we do an examination under anesthesia and we stage, depending on the stage, as we've said, starting from from 1 to 2A, we do surgery, and then all the other stages we apply the radiotherapy and chemotherapy. Then beyond that, we usually do a palliative care. That's why we usually have to send patients to the hospice clinic for follow-up and pain management. So, what are the preventive measures we need to to know? Remember, we talked about the risk factors, and the risk factors we said we have the early sexual debut, and also we have other issues to do with multiple sexual partners, HIV infection. So for us to prevent, we need to delay our first time to have sex. That means you delay the young girls need to delay their first time to have sex. Then if we need to have sex, we need to also use condom. Then also we need to do circumcision, that's including the penile hygiene for our clients. Those who are uncircumcised, they need at least to consider circumcision. And then we need to stop smoking. And also we have HPV vaccination. That is, we have the primary prevention, secondary prevention, and tertiary. And currently we are talking about the primary prevention, where we need to vaccinate our 9 to 14 years of age.
And then sanitizing.
So, what are the key components for us to prevent? It means that's across all of us. We need to play a role starting from the community to the high authorities and to the other places. So for the community, we need to give them information, they be aware, and they become advocates for this screening and treatment because remember, when we do early detection, we can be able to curb this problem. And also with the policymakers, they need to support the system to run smoothly. And also we need healthcare providers to be more trained, to have more skills about the same. We need also, there are several things that play part. We need commodity supply, because remember, there are very few treatment sites, especially for advanced stages of cervical cancer, or those which offer radiotherapy. And we need really to develop our system so that we can be able to have those areas in several counties or several places, so that we can be able to at least help these women who are suffering from this disease. Otherwise, I think we need to stop cancer, cervical cancer, we need to make early diagnosis, and we need to treat these mothers when we get them. So let us utilize the screening that is available within our reach, within our facilities. Let us all be ready to be treated in case we are having a positive lesion. And also, let's embrace HPV vaccination. It doesn't harm anybody, but it is safe for our girls. Thank you so much. Thank you for taking so long. And sorry.
Thank you, Josephine. This was wonderful presentation, and now we really appreciate you as the clinician aspect of how informative your presentation was, from the screening, from the suspicious lesions, from the pap test results, from the symptoms of the cervical cancer screening, and the clinical staging. We learned a lot. All of us learned very much. It was a very informative and very wonderful presentation. Thank you very much. I really apologize. We had to rush you because of the timing. So we have a few questions that have been directed, and they've been directed to our first presenter, Mona Karama. So I'll start with the first question. I think they're all directed to Mona Karama. So the first question is, do we have facilities for cervical cancer treatment other than Kenyatta National Hospital in Nairobi? And there's a comment that we can also start thinking around the role of young men and young dads in cervical cancer prevention. So that is very true. We need to